Okay, so today's topic is chronic kidney disease. So today I plan to discuss a little bit about epidemiology, definition, etiology, pathology, complications, factors of progression, management, and renal replacement therapy we will be discussing at the next session. So if you go through your Kumar and Clark, you will notice that of the two biggest sections in the Kumar and Clark, one is your ischemic heart disease chapter, and the other chapter is on CKD. So after the lecture, spend some time going through the lecture notes as well as the textbook, because this is a large topic, I can't discuss all of the aspects during one lecture session. So you'll have to refer to your textbook to get more information on these areas. To start with, we'll take an example, a classic patient you will see in your day-to-day ward rounds. A 59-year-old male patient who's presenting with non-specific abdominal pain, mild ankle edema, and in the past medical history, he's got a chronic back pain going on for 5 years duration, for which he's on non-steroidal anti-inflammatory drugs. On examination, he's pale, blood pressure is 170/80, and there is a serum creatinine of 310 micromoles per liter. So if you can't remember the reference range, generally up to about 100-110 micromoles per liter is considered normal. You can see that this is 3 times the normal range, so it's high. So how do we approach a patient like this when they present to the ward? The first question you always ask when you see a high serum creatinine value is this acute kidney injury or is this chronic kidney disease? So acute kidney injury you have already discussed with Professor Jayalal, and today we look at the other side of the coin. Now, in order to know which is which, you need to know the definition. So the definition of CKD is it's defined as abnormalities of kidney structure or function presenting for more than 3 months with implications for health. Now, this is a definition which you need to memorize. Similarly, AKI definition is also something you need to memorize because this will be asked in your theory as well as your clinicals. So the important to know are abnormalities of the kidneys lasting for more than 3 months. So this 3-month cutoff is there so that you can differentiate it with acute kidney injury. And if you remember the lecture done by Professor Jayalal, he would have mentioned to you that we talk in terms of hours to days when we are talking about AKI, but here to call it CKD, these changes should last for more than 3 months. And the other component is it has to have some abnormality of kidney structure or function. So when we are talking about structure or function, so these are some of the abnormalities you need to have. Patient could be having continuous proteinuria and albuminuria of more than 30 grams per day. Urine sediment abnormalities, for example, things like continuous hematuria, things like that going on for more than 3 months. It could be electrolyte abnormalities secondary to tubular problems. On a biopsy, if there are abnormalities on histology, if there are structural abnormalities, for example, a unilateral kidney, horseshoe kidney on ultrasound scan, hydronephrosis, those are all considered abnormalities. Or if you are going by function of the kidney, if you have a GFR of less than 60 ml per minute per 1.73 square meters, any of these abnormalities is considered abnormalities. And if lasting for more than 3 months, that is considered CKD. Now, if all this time, if you had thought that to call it CKD, you need to have a high creatinine, that is incorrect. Even with a normal creatinine, if you have any of these above abnormal, if they have proteinuria, any of these, still with a normal creatinine, you can consider it as a CKD if they are lasting for more than 3 months. So the abnormalities of the function, the best assessment is GFR. So you have to have it to be less than 60 if you are going by the kidney function. And when we talk about kidney function, GFR, the way we normally look at GFR is we have a creatinine value and you extrapolate your GFR by putting this into an equation. So if you remember your physiology days, you would have been taught how to calculate GFR by using things like inulin clearance, para-aminohippuric acid clearances. Those are the gold standard ways of calculating GFR, but it's only done in a laboratory setting. In the clinical setting, the best way to assess GFR is by doing a 24-hour creatinine clearance. So for that, you need to collect your urine for 24 hours, take some blood samples to calculate your creatinine as well. But as you would realize, you can't collect 24-hour creatinine clearances in all patients where you need a GFR. So people have found shortcut ways where the only thing you need to have is a creatinine value, and you have equations where you just put those values into these equations and you get a calculated GFR, which is called an estimated glomerular filtration rate. Now, this current standard equation that we used is called CKD-EPI. This first equation is the one that we are using now, but you can use MDRD also, but the first one is the standard one that we are using now. Now, you are not expected to memorize any of these things, but the easiest way to do this is into your smartphones. You go to your Play Store and you just type in GFR calculator and download it into your phone. There you only have to enter the sex of the patient, whether the patient is Caucasian or not, age of the patient, and the creatinine value, and automatically the software will calculate a GFR for you. So that is the way we calculate the GFR. Now, so the first thing in a patient with high creatinine is we try to identify CKD. So for that you need to know the definition of CKD. Once you've diagnosed CKD, the next thing you need to do is to stage this CKD. There are different ways you can stage the CKD. You can use the cause, the GFR category, the albuminuria. Any of these can be used to stage it. But conventionally, what we mainly use is the GFR. And based on that, we categorize CKD into 5 stages. Stage 1, 2, 3, 4, 5. And as you can see, I've used this tip of the iceberg picture here to demonstrate this to you. And that is to show that it's only the patients who actually develop symptoms are actually the patients who are in these very late stages, such as stage 5 CKD. All the other patients, stage 1, 2, 3, 4, which are considered early CKD patients, they will not develop symptoms most of the time. And the only way you are going to diagnose this patient is by having a high threshold to screen for these patients and performing routine investigations with your high-risk patients. For example, with patients with long-standing hypertension, diabetes. Unless you screen for them, you are not going to detect CKD. And by the time these patients develop symptoms, it's too late. The patient has already come into stage 5, and that is the stage where we can't really reverse all these stages. So that is something important to know. So when we talk about staging of CKD, it's according to your GFR. The first stage is when you have a GFR of more than 90. Stage 2 is when your GFR is between 60 to 89. Stage 3 is between 30 to 59. 4 is 15 to 29. And the last stage, which is the last stage of your kidney function and the worst stage, is when your GFR is less than 15. Depending on the albuminuria also, you can categorize them. You don't need to know this, but what you need to know is higher the albuminuria, higher the stage of CKD. And you can see that if you talk about albuminuria, normally a person will have less than 30 milligrams per 24 hours of protein in their urine, albumin in their urine. If you have 30 to 300, you call it moderate increase. And some people call this microalbuminuria. And if it is more than 300, you call it severely increased, or in certain situations, people call it macroalbuminuria. And this table is to show you both into one diagram. And here you can see on this axis, the higher the CKD stage according to GFR on this side, and on depending on the albuminuria, the worse albuminuria to this side. And these red bars are the areas that are showing worse prognosis overall for these patients. So you can see that higher the proteinuria, lower the GFR, the worse outcomes these patients are going to have. And when you're talking about worse outcomes, it's in any situation you consider, whether it's all-cause mortality, whether it's from cardiac disease, whether it's from end-stage kidney disease, and whether it's progression of CKD, whether it's developing acute kidney injury, all these patients with the lowest GFR and the highest albuminuria are at the highest risk. Right. So going back to our patient again, now this patient presents with this history, and in any patient, we need to do the basic investigations from a renal assessment. That is to have a creatinine, you need to assess the GFR, you need to ultrasonically assess the kidneys, and you need to do a urine full report. These are 3 mandatory tests that all the patients with a kidney disease presenting to the ward needs to have as a baseline test. And you can see here, when you calculate the eGFR in this patient, it has come as 19.2. On ultrasound scan, their kidney sizes are 6 and 7.2 centimeters. And I'm sure Professor Jarat has discussed this with you in your first lecture on investigations. Normally, the kidney sizes would be somewhere between 9 to 12. And here, the kidney sizes are very small. This patient's kidneys are showing poor corticomedullary demarcation and increased echogenicity. All these 3 features are suggestive that this is CKD. And when you do a urine full report in this patient, there is 2+ of protein with occasional red cells. Right, so with that investigations, then we've gone into estimating the proteinuria. So this patient is passing about 250 milligrams of albumin per day. Right. So the first stage we discussed was diagnosis of CKD. Second step is to stage the CKD. And then the third step is to identify the cause of CKD. Now, if I ask you all, if you are in the lecture hall, I would be asking you what are the causes of CKD. And then if I had pointed out a few people, some of you would start off answering like this with different answers all around without a proper system. So this should not be the way. Whenever somebody asks you causes of any particular condition, whether it's CKD or anything, you always need to have a categorization. So causes of CKD, you can categorize into congenital inherited conditions, glomerular diseases, vascular causes, tubulointerstitial diseases, obstructive causes, so on and so forth. So the list is endless. I have only pointed out a few things here, which you are aware of. And I'm not going to go into these causes separately, which will be dealt with separate lectures in the future. Now, if you look at renal pathology in these patients, these lectures have been done for you in your clinical path days. And these are some of the ways that you diagnose these conditions. Some patients you can diagnose with renal biopsies. Some patients you need to have ultrasound you can diagnose. So if you refresh your memory on your clinical path days, what would this picture indicate? Can you remember this picture from your renal path days? And if you look at this, you can see these nodules that are appearing there. And those are nodules, or that is what we call nodular glomerular sclerosis, which you can see in diabetic kidney disease. If you look at this picture, you can see that this is your glomerulus, these are your tubules, and you can see a lot of inflammatory cells in your interstitial. And this is what you call chronic interstitial nephritis, when you have lymphocytes in the interstitium like this. And this is an ultrasound scan of the kidneys. What would be the abnormality that you can see here? You can see that the pelvic ileal system is dilated, and there is evidence of hydronephrosis in this kidney, and that is evidence of an obstructive uropathy. All of these are some of the causes that will give rise to CKD. So whatever the cause of CKD, irrespective of the cause, once the kidney has gotten permanently damaged, the common pathway for loss of nephron mass is common whatever the cause, whether it's diabetes, hypertension, chronic glomerular nephritis, tubulointerstitial, whatever the cause, once the damage has become chronic, with time there will be loss of nephron mass. And then whatever the nephrons that are existing will start to function more. They'll try to filtrate, compensate for the loss of the other nephrons. But with time, they are also going to lose their function. They are going to get sclerosed, and your whole kidney will start getting fibrosed and sclerosed. And then that goes on and on for a long time. That's when your kidneys start getting smaller and smaller with advancing CKD. And that is why on the ultrasound scan, you will notice that there is increased echogenicity and poor corticomedullary demarcation. So this is common to any CKD patient. So once you develop CKD, what are the symptoms and signs these patients present with? And if you can remember that I mentioned, most of these patients do not develop symptoms or signs until they come into stage 5 CKD or late stage 4. So these or most of these symptoms that are shown in this picture are symptoms that these patients are going to develop when they are in advanced CKD in stage 4 and definitely in stage 5. So don't expect these symptoms to be there in stage 1, 2, or 3 patients. They will very rarely be there in those patients. So you can see that this affects almost all body systems in a person. Therefore, CKD is considered a multi-system disease. And I'm not going to go into each and every symptom here, but you need to be very, very familiar with the symptoms that can occur with CKD. So in our patient, if we go back, we have established that this patient has CKD because he's had creatinine high. He's had a lot of other changes of CKD with ultrasound, urinary abnormalities. So this is definitely CKD. His GFR is low and he fulfills the criteria to fall into stage 5 chronic kidney disease. And this patient has been on long-term NSAID therapy. So it's more likely that this patient has CKD because of analgesic nephropathy. So your complete diagnosis for this patient should be stage 4 chronic kidney disease with proteinuria, likely secondary to analgesic nephropathy. So once we made the diagnosis, the next step is to look at the complications related to CKD. So I'll stop there for a minute, and if there are any questions you want to ask up to now, I'm happy to answer. Are there any questions you want me to answer now?
Excuse me, sir.
Yes.
Why do you get abdominal pain with CKD, sir, if you do get?
Yeah, so it's not a common symptom. It's very vague symptoms that they are going to say. They are going to say loss of appetite, loss of weight, aches and pains, back pains, things like that. Those are very, very non-specific symptoms. Generally, simple abdominal pain like in an acute abdomen is not a common symptom that they would complain. But some of the reasons why they would say this is because of the uraemia. Sometimes they can get a bit of ascites, free fluids in the abdomen. Because of that, sometimes they can get a bit of abdominal pain, but it is not a very hard and fast symptom that they are going to have. Okay?
Thank you, sir.
Yeah. Any other questions?
So I also have a question.
Yes. Yeah.
In this history,
Yeah.
we haven't talked about a 3-month history.
Yes.
Are we supposed to take the chronic back pain for the duration?
Okay, so good question, Umagi. So the problem here is now most of the patients, even though the definition says 3 months, most of the time we can't elicit a history of 3 months because these patients either haven't been coming to hospital or haven't been having previous investigations. So we have to always sometimes go by the available information. So here we don't have a 3-month cutoff value here, but we mainly here there is evidence in the ultrasound scan showing very small kidneys. So to get small kidneys like that, it has to be going on for a long time. And we assume when we see changes like that, that this has been going on for a long time. And that is why this patient is having CKD. Okay.
So in without the ultrasound, clinically, there is no way to find out.
Clinically, you can only suspect and manage on your clinical suspicion. So other features are the complications that I'm going to discuss next. So if you start seeing those complications in these patients, that is also an indication that this condition might be going on for a while. rather than being acute. Okay.
Okay, so thank you.
Right. Okay, so with that, I'll move on to the next few slides. Just give me a second. I'll just close the windows because there's a lot of noise coming from outside. Give me a second. Yeah, sorry about that. Okay, so what are the complications? So the complications, I've only listed the main topics here, so I won't be able to discuss each and every complication. So the expectation is that you will go back to your textbook, and in your command pack there are, or in your Davidson's, there are separate paragraphs and sections on each of these complications. Please have a read through and get to know those complications. So just to highlight a few things, uremic complications. Uremic complications are when you are having, when your kidney function is low and the kidneys are unable to excrete all the toxins, you start building up all these toxins in your body, and they will give rise to complications related to this. And when it affects the brain, you call it encephalopathy. When it affects the heart, you call it pericarditis, pruritus, cardiomyopathy, gastropathy. So you can see it can affect any of the body systems. Now, urea alone is not an indication of uremia, as opposed to what everybody thinks. But measuring urea is the only way we can get some idea about the uremic toxin accumulation. But apart from urea, there are so many other little toxin molecules that give rise to uremic complications. So it's not just urea, there are many other uremic particles that will give rise to complications. So that is one. Are you all hearing me clearly, or is that noise too distracting? If somebody can let me know.
So there is some background noise, but we can hear clearly.
Right, because somebody's doing some construction work. If you can hear me, I'll continue, but otherwise I'll have to go down and tell them to stop. Do you want me to continue, or shall I ask them to stop?
We are just fine, sir.
Okay, right. So then the next thing is skin manifestation. So it can affect the skin, and you will have these skin manifestations. I would advise you to go into Google and just type these things, and you will see the pictures related to these skin manifestations. You can have metabolic complications like uric acid going up, dyslipidemias, all these metabolic complications. You will have a lot of neurological complications affecting the central nervous system, autonomic nervous system, peripheral nervous system. You can have complications related to the gastrointestinal system with uremic gastropathy, delayed gastric emptying, and so on and so forth. You can have hematological complications, which are very, very important to know, specifically anemia, where the anemia related side complications are very common in these patients and multifactorial, and I will discuss that in a little bit. You will have cardiovascular disease, which is the biggest killer in chronic kidney disease patients. Nowadays, we say that no patient will die of chronic kidney disease, but most of these chronic kidney disease patients are going to die of cardiovascular disease related to CKD. Because even if you have significant CKD, nowadays you have a lot of other therapeutic modalities like dialysis, peritoneal dialysis, transplantation. So these patients can go on living, but they will die or have a lot of morbidity because of the cardiovascular disease risk which they have with CKD. Now you have been taught that diabetes is a cardiovascular disease risk equivalent. Similarly, CKD is also considered a cardiovascular disease risk equivalent, and these patients are at risk to develop all these complications. And in this is one of the x-rays. You can see this is your spine, and you can see this structure. What do you think that is? That is your aorta that is gotten calcified in a patient with CKD. So there's a lot of vascular calcification that goes on in these CKD patients. Right. Now, next part is a separate entity. You might not have gotten exposed to this aspect of CKD before, but this is the most important aspect about CKD that you need to understand. If you go back again from the beginning, just to summarize, we discussed that first thing we need to diagnose CKD. Secondly, we need to stage CKD. Thirdly, we need to identify the cause of the CKD. Fourth, we need to identify complications of CKD. And the fifth aspect is we need to identify the CKD progression and the factors that are resulting in the progression of CKD. Now this diagram is showing on the x-axis age and on the y-axis your GFR. And the top one, if you consider this one, that is showing a normal person. And you can see that after about the age of 40-45, most of the people, even without any kidney problem, their kidney function will gradually go down with age at a rate around 1 ml per minute per year. So that way you can understand if a person has a normal GFR, and if you are in the lecture hall, I would be asking you what is the normal GFR of a person. And if you can remember, your normal GFR is somewhere around 120 to 130. So let's say a patient is 45 years of age and lives up to an age of 85. You can identify that if the GFR was 120 normally, by the age of 80-85, they would lose about 40 ml of GFR. So when they die, their GFR would be about 85 ml per minute per square, 1.73 square meters. So that is considered normal. But in CKD patients, these patients can progress very rapidly, much more faster than this rate. If a person starts losing GFR every year about 2 ml, you can see how far, and let's say this patient develops a kidney problem at the age of 25, by the age of 60-70, they are going to reach GFR of 10. If they start losing a GFR every year at 3 ml per year, by the time they reach age of 55, they are going to come into end stage or GFR of 10 or less than that. If a patient starts losing more faster than that, every year if they are going to lose 5 ml of GFR, by the time they come to about age 40, they are already in end stage kidney disease. So this is what we mean by CKD progression. The faster they lose their GFR, the faster they are going to lose kidney function and go into end stage kidney disease. Therefore, in CKD patients, our main target is to try and minimize this rate of progression. So in order to do that, we need to know what are the factors that are going to cause these patients to lose their kidney function fast and try and correct that in these patients. Now, these are some of the main factors that will cause CKD progression. And if you go through the list, you will realize that most of these are complications related to CKD. So what that tells you is that the complications that you get with CKD are actually going to make the CKD progress fast. And that is why it's very important that you identify these complications early and treat them, so that will also reduce the progression of these patients. So you can see the lower cause of CKD. For example, if you take a diabetic patient, they will progress faster compared to a hypertensive patient. Level of GFR, for example, a person of GFR of 20 as opposed to a patient of GFR of 50, the 20% will rapidly progress compared to a GFR of 50. Higher the proteinuria, higher the progression rate. Higher the blood pressure or poorly controlled blood pressure, they are going to progress fast. Anemia, high blood sugar, acidosis, all these factors, if you don't correct, is going to cause the kidney disease to progress faster. Right. So because of that, all your patients, when you are suspecting CKD or CKD, you have to actively look for these complications. And that is why these investigations were done in this patient. So you can see then we've done a hemoglobin which is showing a GFR of 7.8, bicarbonate 16, phosphate 6, calcium of 1.8, phosphate 4.2, and parathyroid hormone more than 15 times the normal limit. So by looking at that, what are the complications this patient has now developed? You can see this patient's blood pressure is high, is anemic, bicarbonate is 16, so normally it should be between 22 to 26. This is low, so this patient has metabolic acidosis. Potassium is high, normally it should be between 3.5 to 5. Here it is high. Calcium is low, normally it is 2.2 to 2.6. Here it's 1.8. Phosphate is high and the PTH is high. So all these are complications of CKD, as well as if you don't correct them, they are going to cause faster progression of the CKD as well. And that is the next thing that you need to identify in these patients. Right. Now, once you've established those 5 things, again, I will summarize: diagnose CKD, GF, calculate, identify the stage of CKD, identify the cause of CKD, identify the complications of CKD, identify factors that are causing progression. So those 5 things you need to do. And once you've done that, then only you start managing these patients. And when you talk about management, our main priority is to stop or reduce the progression of CKD by correcting all those complications. You treat the complications, and as I mentioned, you need to instill steps to reduce the cardiovascular disease risk. Delaying CKD progression, like I mentioned, becomes the main thing to do in these patients. So in order to do that, I will mainly discuss a few aspects in the management of these patients. Blood pressure. These patients are going to have high blood pressure, and that's going to adversely affect the kidney function and cause rapid progression. So you need to really control the blood pressure as well. If the patient does not have proteinuria, you target a blood pressure of less than 140/90. However, if the patient has proteinuria, your blood pressure target should be lowered down further to less than 130/80. And the preferred antihypertensive drugs in this group of patients will be your ACE inhibitors and your angiotensin or your angiotensin receptor blockers. If they are not controlling the blood pressure, the next line of drugs should be your non-dihydropyridine calcium channel blockers. Why are these 2 drugs the preferred first-line agent? That is because they control the blood pressure, as well as both these drugs have anti-proteinuric effects. Therefore, these patients are preferably put on these drugs as first line. The next important aspect is your glycemic control. You have to target an HbA1c around 7%. However, if a person is at high risk of developing hypoglycemia, especially your elderly patients, your frail patients, sometimes you might have to be a bit more lenient and you might relax this target and maybe even accept a HbA1c around 7.5%. But on average, you need to target an HbA1c around 7% for these patients. Then proteinuria reduction becomes very important in CKD patients. And like I mentioned, you start drugs like ACE inhibitors or angiotensin receptor blockers. If that doesn't work, you add drugs like diltiazem, which are non-dihydropyridine calcium channel blockers. You have to advise to stop smoking because smoking worsens CKD progression and proteinuria. And you need to advise regarding weight reduction techniques because the obese you are, the more protein that you are going to leak. However, there is a misconception among a lot of patients and even among some doctors thinking that if you reduce the intake of protein in your diet, that's going to reduce the protein loss from your urine. That is a myth and not an accurate thing to do. Therefore, you should not reduce the protein intake in these patients. And you should always advise this patient to take a normal protein diet. What will happen if these patients reduce the protein intake is that they are going to continue to lose protein, and at the same time they are not taking adequate protein in their diet, and they are going to lose muscle mass, and they are going to get weak, immunosuppressed and malnourished. Therefore, normal protein diet is what needs to be encouraged for these patients. Therefore, you go for a normal intake of 0.8 to 1 gram per kg per day. And you always need to ask them to reduce your salt intake. This is mainly because of the high blood pressure, as well as when you take high salt, that's going to cause a lot of water retention. in your CKD patient. So you need to ask to reduce the salt intake. And the rest of this dietary management needs to be individualized. So for example, potassium, phosphate, these things will depend on your investigations. If a person is having hyperkalemia, then you need to advise them regarding a low potassium diet. If they are having high phosphate, you need to advise them regarding low phosphate diets. But this should not be a blanket thing for all CKD patients. You need to individualize depending on the need. And when it comes to lifestyle advice, physical activities encouraged, and you need to ask them to at least do 30 minutes of physical exercise 5 times a week. Maintain a healthy BMI between 20 to 25 and stop smoking. Then the other complication and the factor of progression is anemia. Now this slide shows you some of the causes of anemia in a CKD patient. Now if I ask you what's the cause of anemia in CKD, I'm sure majority of you are going to come out with this answer saying erythropoietin deficiency. Yes, kidneys produce erythropoietin, therefore there will be an erythropoietin deficiency in some of the CKD patients, which will give rise to anemia. But that is not the only cause of anemia. There are so many other causes that are mentioned here, which will also cause anemia in CKD. For example, iron deficiency is the commonest cause of anemia in CKD because these patients are having loss of appetite, loss of weight, and these patients are having sometimes occult bleeding because of platelet dysfunction, which will result in iron deficiency. There will be blood loss sometimes because of platelet dysfunctions. There will be shortened red cell lifespan in these patients. The uremia and all will suppress the bone marrow, which will also result in anemia. So similarly, there are so many other causes. Therefore, whenever a patient with CKD comes with anemia, you have to look for all these other causes. For example, you need to do iron studies, blood picture, look for causes of whether this patient is bleeding or not. Before you start giving erythropoietin, you need to correct all the other factors that are resulting in anemia for these patients. Therefore, when you have a patient with anemia, you need to target an HB of at least 10 to 12 grams per deciliter. And when you are managing, you treat the cause of anemia. If they are iron deficient, you give iron. In advanced CKD patients, especially stage 4 and 5 patients, their oral absorption of iron is very poor. Therefore, sometimes you might have to give parenteral IV iron sucrose for these patients. And if those deficiencies are corrected, then only you start thinking of giving erythropoietin for CKD patients. Then the next complication is hyperkalemia. So if that is a complication in a patient, you need to go for a low potassium diet. You need to start giving them calcium binding resins like calcium resonium. And if they're on medications like ACE inhibitors, angiotensin receptor blockers, or drugs like spironolactone, those drugs need to reduce, you need to reduce the dose or need to stop them because that's going to worsen your hyperkalemia. And if a person is presenting acutely with hyperkalemia, you need to manage it as a medical emergency where you know how to manage hyperkalemia as an acute patient. The next broad aspect is what is called mineral bone disease of CKD. Now, I'm not going to go into details of this. I'm just going to give you an overview of this so that you can get some idea and go back to your textbook and read around it in more detail. Now, mineral bone disease of CKD is a broad entity where what happens is when your kidney function goes down, the first thing that happens is the kidneys are unable to excrete phosphate and your phosphate level goes up. And when that happens, that's going to stimulate your parathyroid gland, and the parathyroid gland is, as a stimulus for that, starts secreting more and more PTH. And that PTH will try to reduce the phosphate by excreting it in the gut and the urine. So that's the first thing that happens. At the same time, you can remember from your physiology biochemistry days that your vitamin D is converted to your active form of 1,25 dihydroxylation happens in the kidneys. So in your CKD patients, this doesn't happen, so you end up with a vitamin D deficiency, which will result in again stimulation of the parathyroid glands, which will result in high PTH levels. At the same time, because of the low vitamin D and the high phosphate, your calcium levels are going to go down, and your hypocalcemia is also going to stimulate your parathyroid glands. And so therefore you can see you will have low calcium, high phosphate, low vitamin D, and high PTH in your CKD patients, and all these together you call it mineral bone disease of CKD. And also, if you can remember, this high PTH is going to affect your bones, and that's going to stimulate the bones to cause more and more resorption and calcium release to compensate for the hypocalcemia, and your bones are also going to get affected because of this high PTH. At the same time, all these changes that we mentioned in CKD mineral bone disease, it's going to worsen your bone health, as well as it's going to cause vascular calcification throughout your body. And that is one reason these patients are at a high risk of cardiovascular disease risk, as well as high fracture risk. And at the same time, when you are talking about the bone can get affected in many ways in these patients with CKD. And it is a spectrum of diseases. On one end, you have what is called osteitis fibrosa cystica. And on the other hand, you have what is called adynamic bone disease and osteomalacia. Osteitis fibrosa cystica means when you have high PTH, that's going to affect the bone, and there's going to be a lot of high turnover in the bone, where it releases a lot of your osteoclasts are going to get overactive, and it's going to reabsorb your bone a lot. And that is what happens in your osteitis cystica fibrosa, that end of the disease. On the other end, where you have adynamic bone disease, what happens is, when these patients have high PTH, we as doctors start treating these patients with calcium, vitamin D, and sometimes you can actually suppress your PTH more than normal. And then what happens is your bone turnover is going to become very abnormally low. And that is when you develop what is called adynamic bone disease, where your bone turnover is going to be very low. If you know these differences in just as an overview, that's more than enough. Nobody is going to ask you high-end information about these bone abnormalities. So how do we treat this CKD mineral bone disease? If you have high phosphate, you have to go for phosphate binders. You have two groups of phosphate binders called calcium-containing phosphate binders and non-calcium-containing phosphate binders. Calcium-containing phosphate binder is your calcium carbonate, and this you give when you have a patient with CKD who has low calcium as well as high phosphate. But if a patient is already having normal or high calcium, then you should not be giving calcium-containing phosphate binders, because that's going to worsen your calcium. There you give calcium binders which do not have calcium, which are your sevelamer and lanthanum. Then if you have vitamin D, low calcium, you give calcium supplements, vitamin D supplements, and with correction of phosphate and calcium and vitamin D, if your PTH levels are still going to be high, then you give what is called parathyroid PTH suppressing agents, such as calcitriol or calcium mimetics like cynic acid, which I'm sure you were taught during your pharmacology days. The next complication is acidosis. So your target bicarbonate level is 22 to 26 millimoles per liter. And in CKD patients, these patients are going to have a metabolic acidosis where your bicarbonate is going to be much lower than this. So you have to give oral sodium bicarbonate for these patients to improve this acidosis. And that will help in a lot of ways. It will reduce the CKD progression. It will even improve the hyperkalaemia, reduce muscle catabolism, and improve functions at a cellular level as well. Then the next aspect is your cardiac risk reduction. You need to assess the cardiac risk in these patients by doing ECGs, echoes, and if you think the risk is very high, these patients need to go on statin and antiplatelet therapy to reduce the risk of cardiac disease. The other thing about CKD patients are because these patients are already having low kidney function, these patients are at a higher risk of developing acute kidney injury. Therefore, you need to make sure any risk factor that will cause acute kidney injury, you need to not put these patients through those risk factors or try and avoid those risk factors. Otherwise, these patients are going to develop AKI very easily. And finally, you do all of these things as doctors, and however, some of these patients, no matter what you do, are going to gradually start progressing. And then you need to start thinking of referring these patients to a nephrology service. And these are some of the indications where these patients need to be referred to a nephrology service. Their GFR is less than 30, or if you are having any of these indications, they need to be referred, because these patients then need to be planned for future renal replacement therapy and future management of the CKD. A few words about medications in CKD patients. Always you should avoid nephrotoxic medications in these patients, and the commonest nephrotoxics in our hospital situations are your NSAIDs. So diclofenac, brufen should always be avoided. And contrast studies, where these iodine-containing contrast can cause contrast-induced nephropathy, and those should be avoided if those are not mandatory tests. And at the same time, some of the medications like your antibiotics and your diabetic medications, the doses needs to be adjusted according to your GFR. Okay, so if we go back to our patient, now we've identified these complications, we've diagnosed this patient as having stage 5 CKD. So how do you want to manage each of these aspects in these patients as doctors? So for this patient, his blood pressure was high. So he had proteinuria in his urine. So you need to try and target a blood pressure of less than 130/80. However, even though we like to start ASO ARBs, this patient, we can't use those drugs because this patient is having high potassium. So you need to go for other antihypertensives to control the blood pressure. This patient had anemia, so you need to identify the cause of the anemia and correct it. This patient had low bicarbonate, so you need to start this patient on oral bicarbonate supplementation. This patient had hyperkalaemia, so you need to start counseling this patient about low potassium diet and measures to control the hyperkalaemia. And this patient had low calcium, high phosphate, low vitamin D, and high para-PTH. So this patient had mineral bone disease. So you need to give calcium supplements, vitamin D supplements, and phosphate binders to control the mineral bone disease of this patient. And finally, this patient's main problem was NSAID related CKD. So a patient should be advised to avoid NSAIDs, and you need to go for other medications like your paracetamol, opioids, tramadol, drugs like that, which are not nephrotoxic, in order to control the pain.